So hello again, my name is Ashley Kreider. I'm a Senior Project Associate at Policy Research Associates, and it's nice to see some familiar faces on the screen. Welcome to everyone. I'm going to be giving just some brief context before we turn the virtual stage over to our presenters. So first of all, as I said earlier, we're using the Zoom meeting platform, which does allow you to show video and interact with the presenters and each other. So please keep an eye also on your mute button if you're not asking a question. We have received some questions ahead of the meeting today, so we'll have an opportunity to address some of those, as well as, again, to unmute at the end of the presentations and ask questions live. But in the meantime, we encourage you to please chat all questions into the chat box, and we'll do some sorting and get to those towards the end. We will have a recording link and slides available after today's meeting. Today's webinar is supported by the John D. and Catherine T. MacArthur Foundation Safety and Justice Challenge. For those who may not be familiar, the SJC provides support to local leaders across the country who are determined to tackle one of the greatest drivers of overwhelming incarceration in America, the misuse and overuse of jails in particular, and to create fairer, more effective justice systems. Since the start of the Safety and Justice Challenge initiative in 2016, the MacArthur Foundation has invested over $300 million in local justice reform, and the SJC network has grown to over 65 jurisdictions across 35 states. One of our roles at Policy Research is to provide technical assistance to SJC sites focused on behavioral health, as well as other complex needs, as well as to conduct the research that you'll hear about momentarily. So our presenters today are the President of Policy Research Associates, Dr. Sarah Desmarais, as well as PRA's Senior Research Associate, Dr. Samantha Zatola. So with that said, I'd like to turn the meeting over to our first presenter, Dr. Desmarais.
Thanks, Ashley, and welcome everyone. I'm really thrilled to be here to talk about the research that we did. And this is the culmination of a lot of efforts and interests and partnerships. So we're going to be, as much as we can, sharing those with you as we go through. I also wanted to acknowledge specifically that the research was supported by the MacArthur Foundation through the Safety and Justice Challenge Research Consortium, but that we are solely responsible for the content. So we're representing our views and opinions based on our research and not that of official opinion of the MacArthur Foundation. Today we have an outline for you of what we plan to do. First of all, we'll move into an overview of the project that Dr. Zatola will be giving to us. I'll talk a little bit about the methodologies that we used in this research. Sam will then talk about our project sites and partners. And then Sam and I will go back and forth and share some of very high level, our findings based on this research. And then finally, we'll spend, I hope, a lot of time today talking about our recommendations for sites based on the research that we did. I'm going to pass it over to you, Sam.
Thanks, Sarah. And hello, everyone. Like Sarah said, I'm also very excited to be here today to share some of this work. So I'll give really just a quick kind of overview. We had a pretty large research team. There were 9 of us working on this project because this was a pretty big project. 8 of us worked at PRA in various capacities, doing kind of research, training, technical assistance. And then we had one outside team member who partnered with us, Emily Stuckey, who is the CEO of Archway Institute, which is a nonprofit that supports organizations that work with people impacted by substance use and co-occurring mental health disorders. Emily's also the founder of 2 peer coalitions that focus on advocacy related to long-term recovery and peer workforce development. So she brought a really critical peer perspective to the work that we were doing. And we had 3 kind of overarching goals that we were trying to achieve with this project. First, we wanted to describe the population of people with frequent jail contact. And here we wanted to focus on the intersecting needs and systemic barriers that lead to repeated jail admissions. Our second goal was to identify strategies being used by 3 different sites to reduce people's returning to jail. And here we really focused on collaborating with community-based service providers. And then our third goal was to assess outcomes associated with these strategies with a focus on behavioral health and any racial or ethnic inequities that we saw in outcomes.
Great. So I'm going to talk just a little bit about our methods. So it was just over 2 years worth of work that we did with our partner sites. And we used both quantitative, so based in numbers and data methods, that we're using and capitalizing on at least 6 years of jail and behavioral health administrative data. So these data were collected in the context of routine practice by the jails and shared with ISLG as part of their participation in the SJC network. With our analyses of these data, we focused on our first and third objective. So we used these administrative and jail and behavioral health administrative data to really answer the question around describing the population and their characteristics. We also used this data to really hone in on outcomes that we were seeing. Each site, as we'll talk about in a minute, had a primary intervention of focus for this research. And we use that to look at outcomes, so this data in that way. However, one of the things about mixed methods that really is sort of an advantage, I think, is that we also use qualitative methods in this work. And this is where we can really dig into and get more of the story from people involved. So we did 50 interviews with practitioners and people with lived experience to hear more about these three research objectives. So the qualitative methods actually encompassed all of our research foci versus the quantitative methods where we focus primarily on objective 1 and objective 3. I won't go into the detail of our analytic or statistical methods. I'm happy to answer questions, and we actually have most of our team members on the call as well this afternoon who can answer even more of the specifics of the technical work. But I want to just share one last thing about our methodology is that we integrated findings, meaning we looked at both what the data were saying in the quantitative methods, as well as what the stories we were hearing, what that data was telling us from the qualitative methods. And we used those to come together to understand the wholer picture. So today we're going to use both of those sources of information as we're sharing our findings with you. I also wanted to highlight here that our organizing framework, and many of you will be very familiar with this, was the sequential intercept model. So here, very briefly, the SIM model identifies intercepts and pathways in and out of the criminal legal system among people with frequent jail contact, generally, and really with a primary emphasis on folks with behavioral health needs. So it was really just a perfect match with both the work that Ashley and the SJC network team does in the field, with also driving and helping us hone in on the research that we were doing with our sites. Sam?
Thank you. So I'll take a few minutes to introduce some of the counties that we partnered with to do this project. So we had 3 site partners. We worked with Mecklenburg County, North Carolina, Harris County, Texas, and Pennington County, South Dakota. And one thing that was really great about these partnerships, first of all, they were all just very great to work with. But one thing that was really good is that there was a lot of diversity across these 3 counties. So they were spread across the country. They varied in size. Pennington is a pretty small, kind of more rural county. Mecklenburg is sort of a mid-sized urban county, and then Harris County is a large urban county. There was a lot of variety in the challenges that were most kind of salient or pressing in terms of working with the population of people who were cycling through the jail. There was a lot of diversity in terms of the racial and ethnic groups that were represented across these counties. Mecklenburg County had a relatively large Black population, Harris County had a large Hispanic population, and Pennington County had a relatively large Native American population. And then there was variety in the approaches that each of these counties were taking to try to meet the needs of folks who were cycling through the jail. So we got to see kind of a lot of different strategies represented, and some real variety in the populations that we were working with. So I'll introduce you to the 3 site leads that we worked with from each county, and share just a little bit about some of the strategies that they were using. So first we have Mecklenburg County. There we worked with Dr. Steven Strzelecki, who is the clinical director of the Forensic Evaluation Unit, the County Forensic Evaluation Unit. And you can see on the map that Mecklenburg is in kind of the southern part of North Carolina. In Mecklenburg County, let's see, we have a slide where we kind of highlight what section of the SIM their strategies were kind of centered in. So at Mecklenburg, as we were working with them, we had a chance to see kind of a couple of different programs that they have that were addressing the needs of folks experiencing frequent contact. So at Intercept Zero, they had Promise Resource Network, which is a peer-led recovery and crisis support center. At Intercept One, they had a co-responder program that involved a clinician and law enforcement responding to arrests together. At Intercept 3, they had a robust wellness court program that served the needs of folks with serious and persistent mental illness. And then at Intercept 4, they had another peer-led program that really facilitated connections to community services for folks who are returning from jail or from prison. In Harris County, we worked with Wayne Young, who is the CEO of the Harris Center. The Harris Center provides really kind of a full continuum of services all across the CIM. It includes mental health care, crisis services. They have a peer-run respite center, supportive housing, a lot of services the Harris Center provides across the county. And Harris County is in the kind of southeastern part of Texas. So they have a lot of services there, but for our work with them, we were really focused on a diversion program that they have that was at Intercept 1. This diversion program is a community-based alternative to incarceration for people with mental illness who have been charged with low-level nonviolent offenses, with a particular focus on people arrested on trespassing or picked up on trespassing offenses. And then in Pennington County, we worked with Liz Hassett as our site lead. She is the grant manager for Pennington County. And you can see that Pennington is in kind of the southwestern part of South Dakota. Pennington County also has a variety of services kind of across the CIM. But here we were really focused on a system diversion program that they have that provides an opportunity for diversion in lieu of arrest. Law enforcement can bring people to this service, especially people who are intoxicated, rather than taking them to the jail. And then this service program provides a range of substance use oriented services that fall kind of across Intercept 0 and 1. So this takes us into now our findings. So we're going to kind of organize our findings across the 10 research questions that we asked at the outset of this project. And we'll go through each of the 10 questions and share, like Sarah said, some kind of high level findings. So our first question was, how is frequent jail contact defined? And the short answer is that it really was not defined. We didn't find really evidence of working definitions or kind of sets of criteria that were being used systematically by practitioners to identify who is versus who is not experiencing frequent jail contact. Most often, we were told that these folks are just kind of visually known to staff and to practitioners. So we have this quote here. This kind of gets at a really common sentiment, where practitioners told us, really now that we've been doing this for a while, staff are pre-trained to eyeball clients. So when they come in, staff are like, Johnny's back. That's the second time this month. Some agencies or practitioners generated lists of people who had the most contacts with their services. And then those lists might have been used to kind of advocate for changes in practices, or they were used to collaborate across agencies. So sometimes practitioners across agencies would get together and they would look at who was showing up on their list versus who was showing up on, another agency's list. And then they would talk about ways that they could really kind of work together to focus services on that person. But these lists were just generated kind of periodically after the fact. They weren't really used to proactively identify people when they came in the door and target them for a particular program or a particular kind of service. So this population is not well defined, but they are well known to practitioners. From a research perspective, we looked at the median number of bookings among people who had more than one booking during the range of years that we had data for. So that's how we defined frequent contact. And the median number ranged from 3 to 4 bookings across the sites. So that's what we were using in the research that we did looking at the quantitative data.
Great, thanks, Sam. So I want you to remember this definition for the median number of bookings among people who were booked more than once, because that is what we anchor our quantitative findings on moving forward. And I'm going to touch on a few of them right now. So the second research question that was posed in this project was, what proportion of the jail population is made up of people with frequent jail contact? I wanted to sort of take a step back because we haven't actually clarified the use of our language around frequent jail contact yet so far in this webinar. And we will touch on that a little later when we talk about our policy recommendations. But there's a lot of different terms that are used for this population: familiar faces, VIPs, most visible persons, so MVPs, sorry. We hear things like high utilizers, frequent utilizers, et cetera. And for a lot of different reasons, one of those being what Sam just talked about on the previous slide, is that we felt that we had some concerns around the use of the language that relied on somebody being visibly recognized. And so we'll return to that idea a little later in the presentation. but I wanted to just share that we're very intentionally using the language of frequent jail contact to define the contact as opposed to the person. So with that in mind, the first thing we found very consistently across all three sites, and frankly, this really resonates with the rest of the research literature, is that people with frequent jail contact represented the majority of bookings into the jail during the study period. And for the three jails that we were working with, we had at least 8 years of data. So they were usually half to 2/3 of the bookings. But at the same time, they were a minority of people booked. Again, this is very consistent with how we just conceptualize people with frequent jail contact. So they represented about 1/5 to 1/4, so up to about 25% of the people booked. So most of the bookings, but a small proportion of the people. And these rates were at least as consistent as we saw in other studies, or even a little bit higher. So our third research question was really a very broad one, and it was around describing the characteristics of this population. I'm going to go again very high level here, but these were very consistent findings across sites. So the first thing that we see, which is also very consistent with the jail population overall, is that we saw that they were predominantly men and people of color. So this was true in the general jail population and also very true in the population of people with frequent jail contact. We did see mental health needs at higher rates than we would see in the general population. But this is not to say that it was necessarily characteristic. So what I mean by that is it doesn't mean that the majority of people with frequent jail contact had either indicators or diagnoses for mental health issues or behavioral health issues more broadly. So this means that it was higher than the rest of the jail population, but not indicative of the majority of people in this group. And we can talk a little bit more about that during the Q&A at the end if anybody has further questions. We didn't have access to data on homelessness or trauma symptoms or traumatic experiences in those administrative data sets. But through our interviews with practitioners, administrators, and people with lived experience, it was very unanimously reported that there was very chronic homelessness in this population and also very high levels of trauma and trauma symptoms as well. So even though we weren't able to integrate those findings with our administrative data because those variables just weren't available, this was a very consistent report, and we would consider to be characteristic of this population. The other thing that we heard a lot about in the interviews was about the notion of interconnected needs. So this is a quote from one of our sites, and it's just really speaking to this idea that it's a lot of behavioral health and social needs and issues that are interplaying with each other. And so this particular individual said, I think they're caught in alcohol and drug problems, houselessness, and mental health problems. So our frequent utilizers are going to have a combination of all those things.
So our next research question was, what are the pathways to jail that people are experiencing? And there were two pathways that were described most often by people in our interviews. The first pathway was people cycling through jail on low-level offenses that seemed to be tied to a lack of housing. So these are the folks that are getting arrested repeatedly for things like panhandling or trespassing. The other pathway was people cycling on, again, relatively low-level offenses that seem to be tied to unmet behavioral health needs. So these are charges like public intoxication, possession of substances, also charges like disorderly conduct for folks who are maybe in public parks or downtown business districts who are intoxicated or are maybe displaying symptoms of an unmet mental health need and are getting the police called on them. And you can kind of see that reflected in this quote. So this was a prosecutor that said, he was getting frustrated with seeing people that come in with a rap sheet that's 100 pages long, and it's literally just, disorderly conduct, disorderly conduct, disorderly conduct. So this was kind of a common expression of frustration among the practitioners who were working in the jail that we talked to, or the courts that we talked to. This feeling that, people are getting picked up and brought to the jail, but if their housing or their behavioral health needs are not met, and then they are released, they go right back into the same kind of situation, and it may not be long before they're picked up and brought in again. One thing that I do want to say is that even though a lot of people in conversations were telling us that people were cycling on these low-level charges, we didn't always see that reflected in the quantitative data. In one of our sites in particular, we found that a slightly higher percentage of people with frequent contact were actually cycling on felony charges. So this may be a point where what the practitioners are kind of feeling and seeing on the ground doesn't exactly match up with what we saw in the data, with kind of maybe the bigger picture of what's going on. And it could be that folks with frequent contact eventually start to get upcharged on what they're being charged and brought in on, or it could be that folks with frequent contact, their charges start to escalate during the arrest kind of situation because they're coming into this kind of repeated contact. So this is something that we'd love to investigate a little more to kind of dig into the discrepancy maybe between what, like I said, what practitioners kind of feel like they're experiencing versus what we saw in the data. Research question 5 was, what strategies have sites implemented to address frequent jail contact? So none of the 3 sites that we worked with had implemented programs that were meant exclusively for people with frequent jail contact. We think some of this might be that there were no definitions or criteria being used to identify this population and set them apart as a kind of unique or specific population to be addressed. So because this wasn't happening, the population might not have stood out as a really kind of distinct population, separate from kind of the general churn of folks who are coming through the jail or through community services. So practitioners maybe recognized folks when they walked through the door, but after that, they kind of got rolled in with everyone else who was getting services. And the lack of distinction, I think, may have especially been true for practitioners who worked in community-based services, because they're focused on the people who are having frequent contact with their particular service, which may or may not be the same people who are having frequent contact with the jail. So for them to try to keep track of people with frequent jail contact, in addition to people contacting their services, it's kind of asking them to keep up with a whole sort of separate group of people. And they may not always even know how much jail contact someone is having. They may not have access to that data or that information. And that was kind of articulated in one of the quotes that we have from a practitioner who worked in the main diversion program that we were evaluating for one of the sites. And this was a community-based program. And this practitioner said to us, when you go to categorize high utilizers, there's some that are inherently going to be jail facility high utilizers due to their background, or they have a warrant. And then there's the high utilizers of our services, which includes 3 different programs: crisis care, safe solutions, and detox. So really, when I think about high utilizers, it's kind of hard to say that they're only using one area. So what we really saw is that sites are offering a range of services that are available to everyone. All the sites had strategies that supported diversion and community-based alternatives to jail that, again, were meant for everyone, but were maybe especially serving people who were cycling through the jail the most often. And the inclusion criteria for these programs varied across sites. At one site, the diversion was really focused on people who were getting picked up on kind of substance use related charges. At another site, it was really focused on people who were getting picked up on low-level charges related to maybe mental illness, charges like trespassing. So there were a variety of populations that were being targeted with these diversion programs. And then 2 of the counties talked about having working groups with practitioners across a couple of different systems or services that met monthly to collaborate and talk about the people that they were each seeing in their services and to really strategize about how to focus efforts on these individuals.
So our research question 6 was, who are these strategies reaching? So the first thing that we really saw in the data is that there was inconsistent identification of behavioral health needs. And this was both over time within people. So we would see the same individuals, because again, we were looking at people returning over time that were and then were not receiving flags for having serious and persistent mental illness, for example, or who were being identified as having substance use problems. And now, while we would expect some natural variation in the presentation of behavioral health needs over time, this was very systematic and in a way that we wouldn't expect, given what we know about, say, the course of serious mental illness. So this was, and you'll hear us talk about this again, one thing that we're going to come back to in terms of strategies for identifying people with behavioral health needs. The other thing that we saw in the data across sites is that there was potential indicators of racial bias. So there were inconsistencies in the documentation and the results of these assessments that were being done. And again, we can talk a little bit more about that when we come into the policy recommendations. but it wasn't so sort of variable, or it was systematic enough that it suggests that there was something going on to be indicative of a bias. And so as a result, if we're not identifying people with these needs, then people are not in turn being referred to services. So here, this was a quote from one of our interviews, and it really speaks to this difficulty in accessing mental health services. So many people with frequent jail contact don't see mental health service. I know myself, at one time it was pushed under the rug, so I'm able to talk to them about that. So this was a peer who was sharing strategies for outreach and for talking about and building rapport with individuals who may need mental health services, and then support that use of the service. And this is what we then, sort of see in terms of the reach of the diversion services that all three sites were working on. First of all, we saw that they were, people with mental health needs were the ones that were being reached by these services, which makes sense because all three of the diversion programs were targeting people with mental health needs. We saw some differences, though, in terms of the reach for white people and for people of color. And so, unfortunately, and not necessarily surprisingly, we saw greater reach among white people than we did among people of color. We also saw differences for men and women across sites in terms of who is being referred to and participating in the diversion services. And then lastly, and this sort of resonates with what Sam was saying as well, around the fact that these were diversion services not necessarily intended for people uniquely with frequent jail contact. So the services, the programs were more generally defined, usually around charge level or around specific behavioral health needs, which a lot of people in jail, in these jails have. And so it wasn't just for the people with frequent jail contact. So as a result, it wasn't a specific strategy, nor was it intended to be. And we saw some inconsistencies with which people with frequent jail contact were actually offered and part of the diversion programs.
Oh, sorry, Sarah.
That's okay.
Jumped in too early.
Yeah, so this is just also an example of other services and interventions that were spoken about in the context of the diversion services. And this one was really about the role of housing. So here, the quote is, lack of housing causes disruptions, whether that be because they lose their medication or something else. A lot of times it's not just simply that people stop taking their medications. It is usually a whole lot of other factors. So on paper, it looks like a lot of bad non-compliance, but when you really get to it, it's more like housing instability. So the role of housing was brought up almost in every interview, in every question, in every issue that we looked at. And so we really wanted to highlight here that was also about this reach of services related to behavioral health was very contingent on whether this person had somewhere to stay.
Research question 7 was, how do sites define success? And practitioners really didn't share a lot of concrete definitions or indicators of success in our interviews with them. In fact, success in service was really not a focus of the discussion very often. When it was discussed, practitioners talked about examples of services that they believed were reaching people, or examples of times when they were able to meet a person's needs, or when they thought services were being very well received by people. There were a couple of times where practitioners shared examples that they had successfully gotten someone housed, that they had helped someone get documentation that they had been trying to get, sometimes for years. So these were the kinds of, often it was sort of like small wins that practitioners were sharing. More often, the people we spoke to emphasized the challenges that they were experiencing in reaching people with services or in keeping people in services. And some of that might have been, just kind of the focus of the research. We were asking folks to talk about, we were asking folks to talk about what was working and what was not working, but sometimes I think it can be, examples of things that are not working can come to mind a little more quickly. Practitioners were also just very focused on the people that they were currently seeing. And they weren't really talking a lot about folks that they used to work with that they didn't see anymore. So if a person is successful and stops returning to services, they might not necessarily stand out in a practitioner's mind as someone who was successful and has moved on, especially because so many practitioners told us that they weren't really tracking people in a very kind of specific or intentional way. So it may be hard to notice when a person has, been successful and stopped coming back for services. Of the people with lived experience that we talked to, they often talked about success as stability. So they talked a lot about being in stable housing, being in recovery, having consistent access to medications and documentation that they needed. IDs came up very often, things like IDs and birth certificates, getting those documents and being able to hang on to them. One practitioner who was a person with lived experience felt that they were successful because they had found a way to transform their very negative experience with the system into something that they felt was productive and was allowing them to help others. So that was how this person kind of defined success.
So I'm going to wrap up our last 3 research questions. I just wanted to acknowledge that I'm seeing some chats come in and some questions that are very specific to the research methodologies. So what I'm going to do once I get through these last 3 questions is I'll address those before we launch into our policy recommendations. So I want to also say that because we had 8 years of data, and if you just do the math, this covered the period of the onset of the COVID pandemic. So when we were doing our site level outcomes, when we were looking at the systems in kind of the whole system as opposed to at the person level, we did account for the impact of COVID, and all of the findings that we're reporting on are in a sort of after already considering what the impact of COVID was on the jail population. So when we were looking specifically at the impact of these 3 diversion programs, we saw reductions in jail bookings across sites specifically associated with those programs. And so, at the very short kind of summary is that these diversion programs worked at doing what they were supposed to be doing. Now, in terms of what that means more concretely, we didn't necessarily see changes in booking rates for everyone. So it did seem to be more specifically for some groups. So in fact, in one of the sites, we didn't see a change in the rate of bookings for people with mental health needs specifically. And in another site, we saw increases in bookings for some sort of categories of charges. And so the example here is that we did see decreases in the rate of misdemeanor charges, bookings with misdemeanor charges, but we actually saw an increase in the proportion of felony charges. So overall, I think it really speaks to the real potential effectiveness and role of diversion programs in terms of addressing the issues of the misuse and overuse of jails. But at the same time, it's not going to be one thing that solves the problem or one strategy, and that there's really going to be, a lot of nuance to understanding how these work. So then when we looked at the case level, so remember the previous slide was about the entire population going through the jail, and now we're looking at the person level. So here, when we consider specifically people with frequent jail contact, we did see decreases in the average number of bookings. The caveat is, of course, that we had a shorter follow-up period for the post-diversion period. So most of the diversion programs had been implemented in roughly the last 5 years. And so we had more data in front of that than follow-up data. We did see some changes in average length of stay. And in fact, there were some increases for some. And that makes sense given the change in the mix of charges that we might have seen and the types of cases that were going through the jail. But we did also see, which was the hope, decreases in lengths of stay for others. So again, a lot of nuance and a lot of evidence that the interventions are not necessarily impacting individuals across groups in the same ways. So our final research question 10 was, are outcomes distributed equitably? And you might be picking up a trend from the previous slide. The short answer is no. We saw overrepresentation of people with frequent jail contact for people of color. And this was overall in the population of the jails and also specifically within people with frequent jail contact. And then we also saw that these racial disparities persisted in outcomes. So even though there was effectiveness overall in reducing the number of bookings, for example, and also for some in reducing the length of stay, we saw what could be potential evidence of exacerbation of racial disparities, meaning that the proportion of individuals in the jail was sort of trending upwards towards more people of color instead of less. So that's a very high-level summary of our research findings. I do want to just address a couple of the questions that are more kind of methodology types of questions. So the first one was about our definition for bookings versus admissions. So we used the jail data. So it was truly anybody that showed up and that was booked into the jail and was documented in the jail's administrative data set. So we didn't exclude anyone that had a short period of stay because we were very interested in everybody coming through the jail. It would have been whatever that local jail was documenting in their administrative records. Because of that, we also then had a combination of pretrial and post-adjudication individuals in our data sets. Were there also people who were high utilizers of hospitals and ERs? Well, my anecdotal answer would be yes, but we did not get data from hospitals or ERs. So our definition of frequent contact was very specifically about frequent jail contact, and we did not have data on emergency response or hospital use. And then I think the last one that I'll just touch on here, only to say that we didn't actually look into this all that much, but we know that there were sites that were using releases of information as part of strategies for collaboration across sites. So that was absolutely being done. Some places used them, some places did it more informally, but it wasn't a real focus of the specific research project. All right, so that's, again, a very short summary of over 2 years of work. And now we're going to talk about what we believe to be some very actionable policy recommendations based on our findings. So one of the products we created following the conclusion of our research was a policy brief. This is available on Policy Research Associates' website. We're going to share out the links once the webinar is over. It's also available on ISLG's website and SJC's website. You can find it everywhere. So we came up with 9 specific policy recommendations, and we're going to go through each one of those in turn very briefly today. All right. This is mine, right? Okay. I lost the place in my notes. So the first one is about creating a data sharing ecosystem. So here, actually, some of the questions that came in before the webinar was about, encouraging data collection and data sharing. And this is, in fact, one of our recommendations. So there's a lot of examples and evidence to show and how people can go about doing it. In fact, it's a lot of the TA work that folks at Policy Research Associates engage in is supporting this. So we do recommend a common data sharing language and platform across criminal, legal, and behavioral health systems. It sounds easier than it is. It's actually a very big lift, and it will take time, but it is possible. We highly recommend data dashboards where we can see this in real time. These can be regularly updated data use agreements. So again, just sort of touching on this release of information idea, but also on data use and data sharing agreements. And then finally, where there are concerns related to privacy or protection of data, there are ways to limit data access as needed via firewalls. So these are all challenges, and this is our recommendation number 1 is actually a very hard recommendation, but there are strategies that we know to be effective in being able to support this.
All right, recommendation 2 is to establish jurisdiction-specific definitions of frequent contact. So jurisdictions really have to define this group so they know who is in this population so that they can look at the needs, the specific needs that this population has, the patterns in cycling, and can really focus tailored services and efforts on these individuals to meet their specific needs and try to reduce their cycling through the jail. So there are 4 criteria that jurisdictions can use to establish a definition of frequent contact. And we developed these criteria by looking at how frequent contact was defined across a little more than a dozen reports and papers that had taken place across the country. And we kind of distilled all of those definitions down into these 4 criteria. So the first criteria is the type of contact. This can be, this is the specific jail or other criminal legal system contacts that are being measured. And this can really be anything, whatever is relevant to the goals that you as a jurisdiction have in working with this population. So it could be arrests, it could be bookings into jail, convictions, 911 calls, admissions to a service provider, whatever is relevant to the goals in working with this population. You might count each contact, or you might consider the time span of the contact if that's more relevant. So it might be that you're counting the number of admissions, or it might be that you're looking at the number of days that someone spent admitted to a particular service. The next thing to consider is the number of contacts. So this is the boundary that a jurisdiction would set. Anyone below this number does not have frequent contact. Anyone above this number does have frequent contact. And there are kind of two ways to set this number. You can either set a threshold, 3 or more contacts. Maybe you look at like the median number of contacts that people have over the course of a year, like we did in our research, this research project. You can also look at a proportion of the total population being booked into the jail. So you could take, all the people who were booked into the jail over a 3-year period and look at maybe the top 100 people or the top 800 people, depending on the size of your jurisdiction. So those are kind of two ways that you can set the number. The next is the time period. And so this is the time period over which you'll kind of count or track the number of contacts. This might be 1 year, 3 years, 5 years. It might be shorter, like 6 months. This really depends on whatever you have the data to be looking at and whatever is kind of most meaningful. So certain kinds of contacts may be better counted over longer periods of time, and other contacts might be better counted over shorter periods of time. It's really kind of whatever makes the most sense and is the most relevant. The last criteria is to consider additional systems. So if you're trying to develop a definition within one system or within one agency, you might just use the first 3 criteria for that definition. But if you want to develop a definition that goes across systems or across agencies, then you'll use kind of the first 3 criteria within different systems and then bring all of those criteria together into one definition. So at the jurisdiction level, frequent contact might be defined as something like a person who has 3 or more bookings, 4 or more ER visits, and spends 6 weeks in a homeless shelter over a 2-year span. So anyone that falls into that kind of broad category then has frequent contact across services in a jurisdiction. So jurisdictions, again, can kind of do this 2 ways. Each agency and system can develop their own definition, and then agencies can come together and kind of collaborate across each other. Or you can set sort of one large definition that goes across the whole jurisdiction. Again, this is a very kind of local decision. It depends on who all is kind of at the table, who all is bought in, what you have the data and capacity for. This really can be a very locally driven decision.
I'm just going to jump in to add one thing, if you don't mind, Sam.
No.
We think that it's incredibly important to have these formal definitions, because what we ended up seeing in our research is that the people that were identified using the eyeball method, or that they were learning to recognize those people coming through, didn't encompass the whole population of people with frequent jail contact. So there was definitely some bias in people that were recognized versus not, who, some did and did not actually meet a more formal or set criteria for frequent jail contact. So that's really part of being able to not only track this population, but also identify them and provide services.
Yeah, thanks, Sarah. Our next recommendation is to use validated screening tools. These tools alert you to who should get further evaluation, who might need targeted services, who might be eligible for behavioral health diversion programs. These screenings should be universal, because this will give you a more accurate picture of the prevalence of mental health or substance use needs in your jurisdiction. And because the tools are going to be more accurate in identifying possible mental health or substance use needs than some of the other methods that sometimes get used. So exactly kind of like what Sarah just talked about, the eyeball method is often used to kind of identify people who might have needs, but that's not going to be as accurate as a universally applied screen. These screens are also more accurate than relying on kind of historic files, information in someone's record, because these screens are going to tap into kind of the current symptoms that people are experiencing. So they'll give you a very current, present kind of picture of the needs that a person might have. So we have here some examples of mental health, trauma, drug, and alcohol screens that are all very kind of short, they're free, they're easy to apply. And we suggest that you share the results of these screens with appropriate partners. So this can really facilitate case planning. It'll prevent people from having to be asked the same sets of questions every time they kind of move to a different system or service if this information is shared. And then finally, we really encourage folks to implement some quality improvement protocols. So it's not enough to just kind of implement a screen and then never look back. there has to be protocols in place where someone is responsible for checking in periodically to make sure that the screens are being filled out correctly, that they're being followed up on appropriately. That's a really important piece of implementing universal screens. Periodic booster trainings can be really valuable in making sure that there is the appropriate kind of quality control happening.
Great. So another recommendation was about the implementation of psychiatric advance directives. And so this is really about tapping into people's sort of needs and desires for directing and determining their psychiatric treatment during periods of time when they're not in acute crisis or experiencing severe symptoms. And we don't talk about it a lot or enough in the context of criminal legal system involvement. So it's something that we felt was very important to bring to the forefront. And we also have members of our team who are experts in this area. So they also reduce the need for coercive interventions, which of course are things, very controversial. We talk about it a lot in this space. And so this is just really one strategy that would get ahead of, quite literally, the need to go down that path. PADS also help speed up receipt of treatment because in the context of involuntary treatment or coercive interventions, you would already have the real advance directive regarding what this individual's needs are, and it would preclude a lot of paperwork that you would need to go through to get to that point. So it really does speed up access to services. There are, of course, challenges and considerations. So it's really important to protect confidentiality when implementing and using psychiatric advance directives, but there are a lot of strategies to do so. And we really advocate for the role of peers in being kind of having a significant role in this process, and frankly, in all of the recommendations we're making, in all of the processes. But here to help people complete psychiatric advance directives and to really be a support and also a strategy for ensuring that these PADS would get done. So this is something we felt very important, which is not a typical or usually thought of recommendation in the context of criminal legal involvement, but that we felt was really important to talk about in terms of especially this very short time frame of contact with jails. So a related recommendation was for the facilitation of jail in-reach programs. And I do think that there's been a lot of increase or attention to this in the last decade, but it's still something that we could do more of. So here, jail in-reach programs really are about allowing practitioners from the community to meet people who are in jail before they are released. And here we know that the continuum of care is incredibly important. We know that trust is incredibly important. And all of these things will just help promote the likelihood that an individual has that continuity of care, does show up at services after release. So, for a lot of different reasons, it has a lot of advantages. We also know that it's challenging to implement. So one of the recommendations we have is around following the APIC model, which is the Assess, Plan, Identify, and Coordinate model. And really, there's a lot of guides that Policy Research Associates, the Council of State Governments, and others have been involved with in developing concrete strategies and steps for each one of those processes or phases of the APIC model. The other thing that we'll say here is that this is another example of where there is really a lot of multi-system collaboration that is needed, because for jail in-reach to occur, we do need to have systems willing to talk to each other. So typically the in-jail mental health provider is not necessarily going to be the community-based mental health provider. And so there's going to need to be permissions and strategies to not only quite literally allow the providers into the jail, the practitioners, but also to even alert community partners when there is somebody who's going to be released in the near future or even imminently.
Thanks, Sarah. Our next recommendation is to increase peer support programs. So peer support should be a key feature of policies designed to reduce frequent jail contact. As you're implementing peer programs, it's important to look into any state requirements that may be in place. There are often requirements around certification or training or education. So it's important to kind of look into those and know what those requirements are. You can also look into SAMHSA, the Substance Abuse and Mental Health Services Administration. They've put out a great resource that details some of the kind of core competencies for peers. You don't have to reinvent the wheel when it comes to developing a peer program. So if you're in a system that doesn't have a peer program, it can be worth looking into agencies like nonprofits or behavioral health providers in your county who may already be using peers. And this can be a great opportunity for collaboration then. So to have those peers kind of coming into your system, and then they can really be key in connecting people back out to the community-based nonprofits or behavioral health services. Finally, peers have to be approved to make contact in jails. When people are booked into the jail, most of them are not there for long. So it's critical for peers to be able to get into the jails for that really brief window of time that they have to make a connection with someone. Our next recommendation is to improve access to housing. I know that this one, again, is so much easier to say than it is to actually do. This is a really big recommendation. But like Sarah said, when we tell you that every single person we talked to in every county raised the issue of housing, we're not exaggerating. That came up again and again and again. So programs serving people with legal histories or behavioral health disorders should actively participate in their local Department of Housing and Urban Development continuum of care, so that these programs then can be tied into kind of a coordinated entry system and know about all of the available housing opportunities. It's really important also to work with public housing authorities to make sure that people aren't just being flat rejected from housing based on legal histories without kind of consideration of mitigating circumstances that they might have. It's important to develop relationships with landlords and apartment management companies. A little education with these groups can go a long way. So talking to them about what housing vouchers mean and how they work can be really helpful to kind of increasing their comfort level with accepting housing vouchers. Informing them about HUD-funded landlord incentives to kind of get them on board with housing folks who may be coming in with vouchers or particular kinds of histories can be another really helpful way to bring them in as partners to improve access to housing. And then consider data sharing with housing authorities to create dashboards that show kind of available housing, because this can really facilitate quicker access to housing.
Thanks. So our 8th recommendation was about strategies to increase the use of community-based services. And so this sort of feels like a no-brainer. We probably didn't need to do 2 years of research to be able to tell you this, but we have some specific recommendations or our strategies based on that work. So one of the things that we recommend here is about helping people navigate the continuum of care. For example, warm handoffs or shared video chats or other strategies to help people move between systems and settings. And again, we talked a little bit earlier with the APIC model and the jail inReach. The idea here is all the different strategies that we can do to promote trust and ensure engagement. Other strategies are less about the service, the community-based service itself, and more really about helping people get there. So putting in resources and efforts to support transportation. So for example, depending on your jurisdiction, taxi vouchers or coupons or vouchers for Uber or Lyft or whatever those options are, bus passes, things that will reduce one of the very real barriers to care, which is quite literally getting to that site for that service. We saw a real boom during the COVID pandemic that continues to some degree around telehealth options. And this is just one more strategy, particularly in rural communities where we did some of our work to support access to services for complicated and overlapping needs. And so to the extent that we can really develop telehealth options that are open to and targeting a population of people with criminal legal system involvement, as well as these interconnected needs, we're just even more likely to, again, overcome barriers to service access. The other thing related to this here is around ensuring that these telehealth options are considering both the role of or the reality of criminal legal system involvement and the integrated treatment of co-occurring disorders. For several decades now, we've recognized that treatment for behavioral health issues is much more effective when it's done together, treating it as a complex, interconnected set of disorders rather than considering them separately. It also reduces then the amount of services or types of services that folks are trying to coordinate and try to access. Highly recommend the use of the SOAR model to access supplemental security income and Social Security disability insurance. So for those of you who don't know, the SOAR model is all about improving the quality and quickness with which these applications are processed. And so here, for folks who may not have other resources to pay for and access services, using and capitalizing on the fact that we have the SOAR model across the United States, and also the TA Center is run by Policy Research Associates, so feel free to reach out if you have questions, is really one sort of key strategy to very quick and kind of use that relatively quick access to resources to support access to services. The last thing that we'll say here is that we are focused on quite a transient and cyclical population, people who do, and by definition, are coming in and out of jail and in and out of services. So really recommend that community-based services that are open to and especially targeting people with criminal legal system involvement should use an open enrollment method. So there's two types of models. One is open enrollment, where you can join any basically session or week when you're ready and able. So it could be, that it's a Wednesday and the next session is on Thursday and you can go attend. Closed enrollment models require that all of the sessions in that program be completed before the next the next cohort starts. So you can imagine with a closed enrollment model, somebody gets out on a Wednesday, but there's still 13 weeks of classes that need to be completed before they can start the program, right? So that person is very quite likely to, first of all, not receive services in a timely fashion. And also, what we know about this population is that it's a high risk period, those first 3 months, for return to jail. And so quite likely we might actually have that person come back to jail before the class opened for them. So really advocating for community-based outpatient services that use that open enrollment approach. And then last but definitely not least is really picking up on the fact that we didn't see any of our interventions or any real effective reductions in racial disparities in our research. And so we are just really, this is a call out to the field and to everybody working in this space to center and evaluate efforts for racial equity. Reducing frequent jail contact is not necessarily the same thing as achieving racial equity, as we demonstrated in this research project and as many other sites are seeing in their own work. So we need to be intentional not only about addressing the causes of frequent jail contact, but also about addressing the systemic barriers that are contributing to these racial inequities. And those may not be the same things. So we can very well, for example, start to provide services and address behavioral health needs, but if they're not reaching people at the same rates, or if people are not being recidivating or being arrested at the same rates, then we're not achieving this goal. And importantly, this needs to be a center of all evaluation at this kind of place that we're at as culturally, as a community, and as a nation. We really need to evaluate whether or not we are achieving these racial equity goals, and to keep pushing and looking for strategies to achieve them where we're not. And so that's really one of the major takeaways from our work, that while we're seeing much success with efforts to reduce jail contact, we're not seeing them in the same way across groups defined by race and ethnicity. One of the strategies here we really believe, based on our work and our approach, but also more generally, is that there's a role for the voices of advocates, families, and people with lived experience at all stages of these efforts. That they offer some of the missing information that we really need to be able to better engage in efforts that will ultimately achieve, hopefully, racial equity at some point in our future. So that is the last of our recommendations. We have a QR code here, which you can access our frequent jail contact microsite, which is housed at Policy Research Associates and provides all of the different resources that we developed through this project and afterwards. You can access resources like the policy brief. There is a resource that Ashley and Sam developed on how to define this population. We have a podcast that Sam and Lisa Callahan talk at a very high level about our findings. And so there's a lot of rich resources on this site for you to access. I did see a couple questions in the comments that I can address quickly before we open it up more broadly for questions. So the first is about, from Reggie, wellness recovery action plans in addition to PADs, in addition to the PADs. Absolutely. We were focused on the PADs because of the legal authority that they offer, but definitely support the use of WRAP, or wellness recovery action plans. The other question was how APIC differs from SBIRT. So I'm not an expert on SBIRT, but my understanding that SBIRT is about screening, brief intervention, and referral to treatment versus which could be done in addition to the APIC model. The APIC model is really about how to engage in the in-reach into jail. So my understanding is that SBIRT applies across many different settings. This is about how do community-based providers engage in reach, and how do jail providers engage in outreach to facilitate the transfer from jail into the community. We also provide a lot of recommendations in the policy brief and elsewhere for other readings and other resources, for example, on the APIC model and on all the screening tools that Sam shared as well. So we can open it up to questions. If there's any questions from our audience that anybody wants to unmute or put it in the chat. And if not, we can also lean on some of the questions we got ahead of time.
I have a question, if nobody else does. Colleen Clark Bernhardt, Dane County. Curious, given that you've got the microsite and we've done some work on frequent utilization, do you foresee any support in the future? Or, you know, how can counties with SJC or frankly without kind of tap into this and get a little bit more in-county resources?
What a great question. I wish I could say that I can just send you some funds. But we don't have any further resources on this particular research project. We of course have the funding that our team receives through the SJC network, the Impact Network work. I would say that I think there's real interest and appetite for efforts in this space. I can't think of a particular funding opportunity off the top of my head, but I think that there are pieces of it around housing, the SOAR model, and various things that could be resources for you all. I don't know, Ashley or others from the SJC Impact Network side, if you have any thoughts more specifically around, you know, funding opportunities, but, you know, I wish we had money to dole out. Unfortunately, we're recipients of money. We don't give them out.
Agreed. And Colleen, I'm sure you're familiar with Fuse and sort of the housing basis. Sarah mentioned Slant on frequent contact, but we'll do a little bit more digging and see if we can pull together some resources to send out to the group.
Yeah, I mean, and I'm even thinking if we as a county, because this is a critical issue for everybody, right? Like, we wouldn't do the full research project, but I'm just thinking, is there a way a county can, you know, provide funds and kind of get some support around the data ecosystem, you know, like a couple of the key areas? So maybe put some thought to that, as I don't know about everybody else, but we're starting our budget for 2024 next week. So
Colleen, I would also say this is not funding, but one of the resources that's on that microsite is an infographic that Sam and I developed that's specifically around one of the initial pieces defining that population locally. So that is, you know, an area that doesn't necessarily take upfront funding to start, but it might be, you know, where you want to start with the connections that you already have across Dane County. So we'll make sure that's linked.
I did want to, there's a question from Brandon Irwin about whether these communities conducted sim mapping exercises. Yes, absolutely. Ashley and her team and others have been to these sites at least once, but some sites multiple times. That is actually part of how we went through the process of reaching out to potential partners. So partners, sites that we knew quite in depth what services they were offering and that were representing kind of the breadth and kind of foci that we were looking for this particular research project. I mean, It's hard to believe, but it's been over 3 years, I think, since we originally developed this research proposal. So some of that memory is foggy, but these were 3 sites. And in some of our report materials, we include copies of the full SIM maps that were done by PRI staff. Not seeing any further questions from the group right now. Ashley, I don't know if you want to pop into the list of questions, Sam or Alon, if you're on. We could entertain some of those.
Sure, Sam, do you have access? Can you see this?
Yeah, I have a couple of them I can pull up. One of them was, what specific area of overall health do you believe needs more attention to reduce recidivism? So Sarah, you want to go? Oh, well, I was going to say one specific area that Sarah already kind of brought this up, but I think the idea of more services that address co-occurring mental health and substance use needs, that came up quite a bit in conversations with counties, as often a type of service that was not available as much as it needed to be. There often were services for mental health, and then there were services for substance use. A lot of times the model was kind of, well, let's address the substance use first, and then we'll address the mental health needs. But like Sarah kind of talked about, having services that address both of those kind of at the same time together, that provide kind of wraparound support to get at all of those symptoms, and the interconnection between mental health and substance use is really, really important, and was something that the counties all kind of identified as being an area that they were all trying to kind of grow and move into.
Yeah, the other thing that two things that I was going to mention, and relates to one of the other questions we got ahead of time. The first is that I really want to start conceptualizing around housing and housing needs in the context of health. That just came up so much. And, in fact, all 3 sites were working incredibly hard on it. And it's just not something that we think about it in a big public health way. But then when we get down to the specifics of the interventions, it's considered, separate from. So I just wanted to sort of echo and elevate the issue around housing. The other thing that we didn't really see in the work that we were doing is and also by definition, there was a lot of emphasis on behavioral health needs. A lot of my own work and my work with my colleague, Richard Van Dorn, who's also on the call, is that we looked a lot at also being able to address other factors that are leading to criminal justice involvement. In fact, some of my early work in this space was in the Miami-Dade Criminal Mental Health Project, where we were looking at this very small proportion of folks who were having very frequent jail contact, and they were already getting behavioral health services, both mental health and substance use. And the missing piece was also addressing potential, the word is criminogenic needs. And so we don't typically think of criminogenic needs as a health issue, but when we're starting to look and narrow down kind of more and more into this population, there are groups of people for whom there are other factors in addition to, and there's a lot of programs available. They're just not often targeting folks that come through jails. They're often done more in prison settings or longer term stay settings. And this is a space where I think we really need to innovate and think about how do we really look at all the factors that are contributing to people's involvement.
I can jump in with another one of the questions that we got was, what is the role of systems other than criminal justice, such as mental health, housing agencies, and hospital districts? So I think this is something that we also have kind of touched on all throughout, but I think it's probably pretty clear that the experiences of people who are experiencing frequent jail contact, it doesn't happen in a vacuum. So they're often also contacting all of these other systems, and addressing their needs really does need to be a multi-system effort. So that collaboration is really kind of a critical piece of, a lot of our recommendations, you'll notice, are kind of centered around data and information sharing. And that only happens when counties are working together, or when systems rather are working together. And I wanted to kind of weigh in. There was a question earlier about, what was it about? Data sharing agreements. So I've also done some kind of technical assistance with counties, not these 3 counties that we did this research project with, but 3 other counties. And one of the really big conversations that we had with those counties is that those data sharing agreements can sometimes be a really important piece of facilitating buy-in, especially kind of buy-in around like legal departments from agencies or organizations. So kind of having those data sharing agreements in place can sometimes be what's needed to get a certain system or a certain agency to the table. And those could be just really helpful in kind of increasing sharing data, building these data dashboards. So just kind of wanted to chime in with that experience.
Yeah, and actually just scrolled back up through the chat because I knew there was one other question I hadn't gotten to in there. So there's a question about need for services in non-English impacting accessibility or who receives services. So there was absolutely, that did come up. The communities we worked with were also many of them seeking strategies and trying to provide services in different languages as much as possible. But a lot of the communities have a lot of diversity in terms of the language. And so this is a very real issue in this space. The other thing that I would say is also around culturally appropriate services. And so sort of beyond language, also about what services were available, who felt comfortable going to what kinds of services. And so there, is a need for just services more generally. But what we saw sometimes is that there were exclusionary or inclusionary criteria that would, maybe prevent some folks from going to one service or another, or even requirements. Something that came up was around, some housing options that required sobriety, other housing options that actually were only available for detox. And so there's just this mix of different criteria across services and different types of services, and who might be able and qualified to go to some and who might be comfortable going to some. Follow-up question on the SIM. So to my knowledge, the SIM maps for these counties were done at the county level. But I don't know if Ashley or anybody else from your team, you want to weigh in kind of on just SIM approaches?
Sure, I was typing, this will be easier. Correct, generally we map at the county level, occasionally at the city level, especially if it's a larger jurisdiction, but generally county level. If you have some sort of entity in common, like the hospital, or it could be the jail, as we often focus, or some sort of coordinating group within that county, that helps with the diversity, even if it's really regardless of anything, even if it's a large area and has a lot of different players, or not necessarily. So that's kind of the commonality point. But we've mapped very small jurisdictions, the largest jurisdictions in the country. So it generally works regardless of what a community looks like. And we can share more information on mapping.
We probably have time for one or two more questions if there are any questions from the audience. Well, seeing none, I'm also happy to wrap up a bit early. All right. Well, thank you all very much. Ashley and others have provided a lot of links in the chat. So maybe grab some of those before you log out, and appreciate you being here this afternoon, listening about our work. We're incredibly passionate about this area of work, and we'd be happy to answer follow-up questions as they come up.